So as I mentioned, welcome to everyone. Thank you so much for joining us tonight. My name is Melanie Rogers. I am the founder and CEO at Balance Eating Disorder Treatment Center here in New York City. I'm also a clinician myself. I'm a registered dietitian and certified eating disorder registered dietitian and supervisor. And today it is my great pleasure to be the host and moderator for our presentation. As you may have already heard me mention, tonight's webinar is on the treatment of eating disorders in the LGBTQ community. And certainly Shervin is an expert to be presenting on this topic tonight. A little bit about this presentation and its meaning, I think, not just for myself and Shervin, but also for our field. As many of you know, the LGBTQ community is disproportionately affected by eating disorders, yet they are often undiagnosed and certainly not provided with adequate care. There's certainly a gap there. And for the clinicians who are joining us tonight, as we all know, many of us do not get any treatment or very little treatment in how to treat eating disorders, and certainly have not received treatment at all in working with the LGBT community. So tonight, our presenter Shervin, I think, will begin to correct that deficit by providing an overview of key elements of treating eating disorders in this very vulnerable community. I would like to introduce a little bit about Balance before I introduce you to Shervin. For those of you who may not know much about us, Balance is an outpatient eating disorder treatment center here in the heart of New York City. We're still going strong, though. At this time, we are 100% virtual. We have a full day program, an evening IOP program, a Saturday program, and then we have various evening support groups. We have, for example, 2 body image groups, soon to be 3, and we have 2 men's groups, one specifically for men who are challenged with binge eating disorder and overeating. And we also have a radically open DBT class, actually, as they're called classes. We're only one of very few facilities in town that actually are offering RODBT, but I'm sure many of you have heard about the efficacy of that particular treatment modality. In addition to our groups, we also have individual nutrition services and also individual therapy. We are all gender inclusive, and we do treat adults and also adolescents. That's a little bit about Balance, and it's my pleasure to answer any further questions you may have if you are seeking treatment options for your clients or for someone that you know. And now, without further ado, I would like to introduce you to our wonderful speaker. Shervin, are you ready? I am thrilled to be introducing you to Dr. Shervin Shadianloo, who is an assistant professor of psychiatry at Zucker School of Medicine at Hofstra, Norwell, and a double board certified child, adolescent, and adult psychiatrist. He completed a fellowship in child and adolescent psychiatry at Hofstra Norwell School of Medicine. Shervin works at the Center for Transgender Care, Zucker Hillside Hospital, and Lenox Hill Hospital, with a main focus on transgender care. He is the former acting director of the Adolescent Eating Disorder Day Treatment Program at Cohen's Children's Medical Center. Shervin obtained his medical degree from Tehran University of Medical Science and worked as a primary care physician in a rural, remote community before moving to Australia, my hometown, where he was trained and practiced in psychiatry. He pursued his advanced medical studies in New York, and he's trained in DBT, CBT, family, group, and dynamic psychotherapy. In addition to clinical work and teaching, he dedicates his time to working with organizations advocating for the mental health of our society, in particular youth and the LGBTQ+ community. Among his many affiliations, he's on the American Academy of Child and Adolescent Psychiatry's Committee on Sexual Orientation and Gender Identity Issues. And Shervin is the co-chair of the Committee on Mental Health for the United Nations and the Executive Secretary for the Lesbian and Gay Child and Adolescent Psychiatric Association. So what a very, very impressive resume you have there, Shervin, and it is absolutely my pleasure to be introducing you and hosting you tonight. So without further ado, Shervin, if you would like to take it away.
Thank you, Melanie. Thank you, and hello to everyone. I have to make a quick corrections. I forgot. I have a step down from working at the UN, and I've put most of my effort into advocacy. That's my bad. I should have updated that part. And in fact, sort of like part of the talk today is that how for all of us to be advocate. We have lost some very good advocates in this country. We've gained some new ones. As I was sipping on my cup and I thought about like Ruth RBG, whom we lost recently, and so many people saw as her. I would like to start and move. If you give me a second, I'll start these slides by sharing my screen. It is, I have to admit, it is a little bit different. I am a people person, and when I don't see anyone, I have to use my imagination, thinking that I am seeing everyone. Just a second. Melanie, is everything all right now? Okay. The focus as Melanie started treatment of eating disorder in the LGBTQ community. I'm a child psychiatrist, and I mainly work all across the different disciplines in psychiatry. I have a focus on eating disorder and LGBTQ, to have private practice in the city, and I'm also working with Northwell as an academic. Oops, where is this? What happened? Quickly, I thought maybe it's important, I always like it to at least have some expectation about what we're going over as an objectives of our work tonight. So perhaps being able to at least learn together about basics of gender and sexuality development. I am a child psychiatrist. I like development, to look at everything from the lens of development. And along the line of looking at the development, looking at it and thinking about the role of gender and sexuality in the body image. And if you're thinking about eating disorder, really thinking about that in body image as well. And finally, is that thinking about it from the learning and overview of how to treat and work between individuals who have who are LGBTQ and have eating disorder, to integrate the first two objectives and reach the last one, which is the third one. Let me just see if I can, sorry, oh, there you go. Thinking about gender and sexuality, I thought I have this habit at least thinking about the very basic of terminology. Please accept my apology if it feels repetitive. Many people who are listening to this webinar, they might know it way more than I do. Things such as like the very basic wording of it, but I thought it might be helpful to again review them. The whole idea in formation of gender is that it starts with some genetics. Many may have heard of, like, well, everyone probably knows about chromosomes. We all come with sets of chromosomes, and sex chromosomes are pretty important information of our gonads, and they play a significant role in our gender. Not the full role, but a significant role. Things such as XX, most people with female gonads have XS, or XY with male gonads have XY. I don't want to spend too much time on this subject, just want to refer to it. And that's where when we usually talk about the genetics of the gender. Moving on from it, after the fetal life, after birth, when a child is born, have a gonad. And based on their external genitalia, the anatomy becomes actually the first lead on deciding on someone's gender at birth. And that's how the term gender at birth is really like coming from. When someone is born, the gender is assigned at birth. And based on that, says someone is female or male. At this point, almost in all countries, rarely around the world, there is a possibility of assigning someone something except male and female. And that has some connection to gender identity, but not necessarily a lot. It's mainly on the formation of the genitalia at birth. And if someone doesn't have a very clear genitalia at that time, the question is what should be called, and the third gender is usually coming from that. The next subject here, which probably is more relevant to our talk tonight, is about gender identity. Gender identity is one actually sees themselves at what gender they identify with. And that has sort of like, we're going to talk more about it, a different terminology, but it's important to be familiar with it. It is an evolving encyclopedia for itself. Traditionally, the idea was that the two genders, male and female, but we're talking about a concept, an internal concept. Internal concept has no boundaries, like it can actually go as far as people think of themselves. It is very much cultural bound and language bound. The language can define various ways of looking at gender. So as the cultures, many people have heard of two-spirited gender in Native American culture. Different cultures have, like, the majority of them follow the biology in terms of the gonads, into female and male, but cultures have embraced a variety of understanding of gender. And that's in terms of what a person think of themselves inside themselves. It can actually, it correlates at times, but not always fully matches with gender role and gender expression. Gender role and expression are really way more dependent on the culture and the society a person lives in. If you look at the old, for example, paintings from a century or two ago, like if you look at the painting of a little boy, would be in a red dress, velvet, that today's would be considered very female. But that was a typical code of dressing there. So the roles and expressions can change, but there is also some consistency across a culture or in between the cultures as well. And that's where it comes to gender role and expression. And the other subject, which is somehow related, but by itself can be different, is sexual orientation. The terminology here also, I think, is important to know that words such as someone who identifies as gay, as lesbian, as bisexual, as words such as pansexual, asexual. I'm happy to answer questions if they come up about them, but to give an idea, it's about who a person is interested in. Is person interested in the same sex? Often the most common use these words are someone identifies gay or lesbian. Someone may identify as bisexual. There is a new term many people might have heard as pansexual. Means, well, to the eye of most people, is that being interested in a variety of genders. Asexual, not being interested in any gender. I really encourage everyone to use this concept and communicate with the other person what they mean, what they say, rather than necessarily assuming it. Very brief introduction. I'm happy to answer as things come up if there is anything related. I found this probably I always found the gender unicorn, or some people may have gender bread person, very helpful in a sense of conceptualizing what I was talking about in the last slide. But gender identity is what a person has in their head. Gender expression is about, and it's a range of all of them, how they express themselves on the outside. When the sex assigned at birth, some people sex assigned, the gender assigned at birth, both I think are correct, which is female, male, or intersex, which means the genitalia is not quite one way or the other. Oops, oh my God. Physical attracted to either genders or like other genders. And the emotional attraction. And I think what actually the gender unicorn is introducing is going beyond the physical attraction. The person might be physically attracted or not have any attraction to someone, but might have emotional attraction to someone, emotionally being attracted to different genders, but physically attracted to no one. And all of them are possibilities of describing and having more and more elaborate language for people's differences. I'd like to actually quickly move on to what perhaps is more important to our conversation tonight is about, or my presentation tonight is about gender development. The question rises always about when does a person start thinking about their own gender? like the slide says it, if we were like talking, I would always ask people, when do you think the person start thinking about the gender? Interesting enough, it's actually pretty early age, 1.5 to 2 years old. A kid starts, like the people who actually either have a child or raise a child or have a friend who has a child. Like really, when you look at kids, because around age 1.5 to 2, they start having some say over what the preferences are and what they think of themselves. Obviously, it is not developed like an adult. It's not through the lens of an adult, but it's through the lens of a 1.5 or 2-year-old. There are some kids who do want to wear certain type of clothing, and there's some that they actually refuse to wear some type of clothing. And the type of plays and games start coming. Those are in terms of the expression and role, but they also can think of themselves in a particular way as well. And these come together and start growing. Obviously, when it reaches the age of school age, it is more well formed. Kids, as they enter school, they actually have an idea about somehow binary, but not quite binary in terms of like what gender they have. They actually, in terms of the expression, can be quite non-binary, and it's developmentally the most appropriate way a child grows. A child may identify as boy, but really likes playing with Barbie. Might have the genitalia of one gender, but like to do something else. Most of the time, their identity aligns with the genitalia they have and the gender or sex they're assigned at birth, but not necessarily always. And the story can be slightly different. The whole point is that puberty is the big revolution in the body. Before puberty, kids are more flexible and families play a fantastic role. You know, tonight's presentation is really, so some people now sitting on the other side thinking, why am I talking about these matters? There's not, like, I think the idea of this webinar wasn't necessarily for people to be able to work with little kids around their gender. Is having an understanding of it. When you work with an adolescent or an adult who's coming to us, being able to understand their story from the beginning, if there is a material there, and be able to actually go through their story in a better way and have it like, and be able to develop better rapport and their own development. Puberty is the big bang. Body changes, mind changes, everything starts changing. And you'll see it in my future slide. Puberty is going to be the big change in every aspect of it. Gender is the big deal. Secondary sexual characterization starts. People think of their gender. People start dreaming about their own body. It becomes, well, things start changing. The breasts grow. So the breast starts growing. The periods may start soon. If someone has a penis, their penis starts growing and become closer to the adult side. They start having a function for them. In their dreams, they start having functions. Kind of these things are no longer like the same as childhood. The big bang has happened. And following that is the whole adolescent and teenage years, which are quite important and very much relevant to the topic that we all imagine all the clinicians and people are watching this one are one way or the other working with. During adolescent and early adulthood, perhaps like, if not all, but majority of people we are working with, the needs of difficulties around eating start forming around that time. And when we're looking at the gender development, this is the time that gender also starts developing in its own adult form. Adolescent years are the years that the person start like in either embracing or having difficulties. 90-something% of the time, they're embracing the development, but sometimes they have difficulties as well. I think both of them are important to understand when we listen to someone's development. It is interesting. I think that the new age and new world, a new century, things have changed in a sense that developmentally also have changed. If we go to 200 years ago, around age 15, 16, 17, the expectations were for an adolescent to transition quicker to an adulthood role, to have offspring, to work in the farm or wherever they were living, to embrace the role of adulthood, to either marry or have a child. It's not only about the marriage or having a child, it's about actually transitioning faster to the role of an adult. Things have changed.
now we have actually the transition age has expanded itself. The early adulthood plays a significant role in people's development. We go to college, our youth are going to college, even when they don't go to college, they're actually still in the transitioning age to the adulthood. The things are very much open and fluid for them. And that fluidity offers a longer period of time of exploration. And that's a new, I think part of it is also is embraced by the society. And the same thing, so I think sort of when we look at the sexuality development, in some way it follows the same path of gender as well. Kids have sexuality. Kids can think of a play what adults do. In fact, speaking of the culture and media, kids have become more sexualized and not sexualized in some materialized sexual. I'm not talking about the objectified sexualized approach, but also they have it in their stories. Our love stories more present. They think about it more often in their own way. It's very different to the adult sex, but they have their own place in their own way. And when it gets close to puberty, as the gender is developing, sexuality often develops along the line, that one too. And it becomes pretty important post-pubertal. Post-pubertal, the dreams about, not only dreams, sleep dreams, the daydreams, and they play around with their own, the whole kind of thing back and forth between them becomes an important piece. It's not only the media, I think when you look at our TV shows, a TV show like Gossip Girls only talks about drug and sex amongst adolescents and really brings the adulthood roles into adolescent roles. Quite not often that's actually the case, but it is pretty much present in adolescent life and teenage life. They explore it, they are open to see which way it's going, and they transition often to early adulthood around after that age, which the things are still fluid till reaches adulthood, some stability. The third part of this talk tonight relates to the body image and the role of the weight. I put it when I was thinking about it, I felt and I always thought about it, it actually follows somehow the same pattern too. Children's can be very different as their kids. Some kids are so picky with their eating. Some kids are actually very happy with it. Some kids are emotional eaters. This is even before puberty happens, before they transition to the adolescent years. And things such as diet, such as culture, such as genetics play a role in their eating habits and the shape of their body. Some are exposed to body shaming at a very early stage. Some have significant anxiety and it translates into their stomach. People who are familiar with child symptoms, often kids were anxious. One of the first symptoms they feel is through their stomach, they get abdominal pain. So it's quite a very close connection between the mind and the guts as childhood. But obviously, most of us know that puberty is very important around identity. I think what connects all these three of them together is the formation, not only formation is already formed, is maturation and transition of identity from the childhood to the adulthood during the puberty and adolescent years. The sexual attraction is forming, the change in the body, the confidence, all of them impact our body image as well during the adolescent years. And this can continue through the adulthood as well, early adulthood, and followed roughly the same pattern of development, and it can impact the eating pattern. Eating has one very significant factor in it, not only about the body image, but also I think about the confidence and developmental achievement. It's a milestone. A kid is capable to eat and also capable to refuse to eat. I'm saying this again. I apologize if I'm repeating things that you all might know, but I really want to bring it to the forefront of all of our minds, that how they relate in the LGBT community, because I think these matters in some way, as I'll get to them later, really can highlight the difference in the LGBT community, the things that are somehow subtly more present underlying the person identity formation. And that's about the sense of control and the sense of independence. And eating plays a significant role. If I close my mouth, nothing goes down. If I decide to eat as much as I eat, it's my decision. And it's very important in my own individuation. Putting them together, I was thinking how to marry all these three subjects together. Obviously, one of the first things that happens around differences in the society has expectations. Expectations change with society as the culture changes. But often amongst LGBTQ community individuals, from young people to older people, is that the society is often not welcoming. They may have, like, one of the first thing that it starts is that the expectation is that you're straight, you're cis. Cisgender, who is cisgender? Cisgender is someone who is born with a genitalia of, let's say, male and is known as a man and identifies as a man, or has genitalia of female, has gone as a female, develops female sexual secondary characteristics, and identifies as female. This is cisgender. The opposite is transgender, which can be a big umbrella. Can be someone like who identifies as non-binary, can identify as gender queer, can identify as transgender. These terms, if you have any question, please put it in the chat box, and I'm happy to explain about all of them, more about each of them. But a question is, like, the first thing is that, unfortunately, being a very small minority in the society, gender, perhaps around 1% of the society, LGBTQ community altogether, between 5 to 10% possibility, and historically being shown away and being looked down upon, there is this fear of rejection that comes very quickly. Would understand kids start thinking about it at various early stage when they feel the difference, but they talk about it, but they often rejected, humiliated, or feel like different. And that difference brings, what am I going to do? How am I going to fit into the outside? How safe is it going to be the outside for me? Might be feeling of loneliness and need to survive. And these things have to be compensated, have to be addressed. One of the ways, I'm not saying the only way, but one of the ways one person may try to compensate is that referring to the body image, by what society considers a perfect body image, to compensate for this fear of rejection, not to be ostracized, but to be known as someone who can shine, or who is, or as something that actually can stand above others. If this is a weakness in the eye of society, I have something to offer to you to compensate against it. That's one of the hypotheses, perhaps. When someone feels lonely, can actually focus on, can go back to eating and think, and eating can be quite comforting, or can be a way of showing control. A little bit different, but that's perhaps whatever the same pattern and hypothesis that we've had, like with other youth, or other adults, that there is somewhere another form of a stress in their life. We don't know exactly what happened to stress at some point, but the stress can translate itself to either over-control or overzealous control around eating, restriction, or overeating, or really disorganized patterns of eating, and translating into that one, how the emotions can translate that one. Or it can translate to over-control over the body image. It can also be about being how one person wants to perfect their body. By perfecting the body, it becomes a task to, as I said, to counteract the imperfection of being LGBTQ, and and somehow balance it. It may sound trivial, and it may sound nowadays doesn't exist, but believe me, it does exist. Like when you talk to kids, when you talk to adults, even in New York City, there is always a fear of rejection amongst LGBTQ community and youth. It doesn't only stop at society and physiological, and I don't think we should assume that's the only one. It's a possibility. I'm only putting it as a hypothesis, and I stop there as far as a hypothesis. But I want to also put another hypothesis there, is that the anatomy and physiological changes for an LGBTQ person might be different than someone who is cis and straight. Why is that? Well, there might be some distresses around a change of puberty, so mainly with people who actually either have dysphoria about the change in the body, identifying transgender, gender non-binary, or questioning, or also sort of like, or sometimes actually there are some overlaps and gray area. We talked about, I want to refer back to the developmental slides that I talked about, and that's the whole reason. During this phase that is quite crucial information of identity and consolidating a safe identity inside ourselves, that's the time of the change as well. And if there is a question there and the changes are threatening to the person, it can be distressing, the anatomical changes, the physiological changes in someone's body. One of the possible compensation is that by putting on weight in some way to cover up for changes, or actually the opposite, by excess loss of weight, and in that way to sort of to minimize the changes in the way that they are either over masculinized or feminized in some way. Or in another way is that, and none of these ones actually I'm talking about them are necessarily available to the awareness of the individual, pretty often are done and compensated through unawareness and the unconsciousness of the person. I have to say, I have to disclose, I'm very much psychodynamically minded, and that comes from that view. But I don't think it's far too from what most people can also hypothesize about their own, like when they work, or what they can see when they work with an individual. It's not something that one says that I am changing, even though that can happen. I'm changing, I don't like it, so I'm going to eat as much as I can, to be as heavy as I can, to cover my body and not to be attractive or not to look this way. Any of these words can happen. Often is in the back of the mind. Or to stop the puberty. One of the things that if someone is malnourished is going to happen is that the puberty is stopped. The hormonal production is stopped. And that can play a significant role in, if there is a fear behind it, it can play something about it. Well, and let's just think about it, talking about the role of eating and the impact of eating in transgender and gender variant people. I want to a little bit zoom in and go through this one and listen, what is it, what's about it, the last slide around physiology and anatomy of it, and how is it different, which goes actually beyond physiology and anatomy. Perhaps there are some talks, and I think anecdotally, at least at this point, we know that, or at least we suspect that, the rate of eating disorder or disordered eating is much higher amongst gender variant youth. And the possibility is that by suppressing eating or by changing eating, the person's mind is trying to intervene with a process that is quite distressing for the body. And that might be one of the reasons that there is a chance that eating disorder is higher amongst transgender gender variant youth. And understanding this possible processing may help to uncover some of the difficulties in addressing their needs. This is partly based on my own experience and also working with other people who work in this field. And the narrative of the patients that I have worked, that I have developed some of these understandings, the literature and data still is developing. So I cannot say then there is a well-established data. There are case reports that are coming out and talking about the role of eating and eating disorders in gender development in eating disorder, vice versa. Mainly gender development in eating disorder. One of the things, as I said, is about with the beginning of puberty, with suppression of puberty. If someone is starving themselves and malnourished, it works as a puberty blocker. We all knew that. In the past, used to be criterion for anorexia, thinking that they thought that only anorexia happened in girls, or gender assigned at birth, girls better say. Their periods are stopped, the menstruation is stopped because the body's malnourished, production of hormones is stopped. And that actually happened across both in terms of sex assigned at birth, female or male, regardless of their gender identity. But the gender identity can play a role in a sense, if there is a discordance there, by stopping that, the kid can stop their puberty. And that can be the beginning of the whole cascade of eating disorder in future by starving themselves. Not only the periods stop, the sperm production can stop too, the testosterone can stop too, and the body can, it can also stop masculinizing. It also like can avoid changes. Not only the puberty can be slowed or stopped to a degree, it also can mask or avoid changes by the change in the body form, like by restricting eating. Often by restriction in eating is that the body doesn't look very feminine or very masculine, goes but like it looks like a child again, the body regresses back to prepubertal stages. The same hypothesis in other forms has been used in eating disorder. I think this one here can also be used, but it has been present in the narrative of individuals that I have worked with and many people have worked with who are gender variant or transgender and have had an eating disorder. Sometimes the attempt is to reverse some of the changes. If the breasts have developed by losing weight, they're going to shrink and get smaller. If the body has masculinized by losing weight, the muscles are going to shrink and will look less masculinized, will look more petite and feminine in that way. It does reverses of the changes. The hair growth will stop in some way because the testosterone has stopped. The periods will stop. They reverse some of the changes, not only stop them, might reverse them too. Or there might be some other reactions that we still don't know, but there seems to be some correlation between these two together. So the question is that, well, we have LGBTQ people, and like we talked about the importance of understanding someone's gender and sexuality as we're working with people. People don't come, it's not a blood test like, you know, and then don't come necessarily with their rainbow flag or their trans flag into our offices and saying that, hey, I am. Some people do, but some people don't. And that's actually, that becomes like a question, how to ask and who to ask. Should I think about a young looking boy coming to my office who is effeminated and thinking this person is genderqueer, transgender, or gay? Or should I think about birth sign, or like what I think as a female coming to my office who's tomboy is thinking this person might be a trans male or might be lesbian? This is often what our mind has helped us based on what? Based on copying. We see something, we record it, our mind refers to that person. That has proven to be the worst perhaps approach, is based on assumption and stereotyping the individuals. One of the best things that I always suggest is that might be very familiar for everyone here is that be neutral. Like really thinking about the most feminated person, boy who comes to your office might be straight and cis, and the most masculine looking person might be gay or might be actually a trans woman who has not come out of their closet, or that person has not necessarily felt comfortable to either even access it to themselves or to ourselves. I don't think they're coming out necessarily to society. The suppression may be to the point that it might go fully to the unconscious of a person. Hence, people will start coming out in their 20s, 30s, or 40s. It's not that they just woke up one day and there was this light bulb in their head and they find out something hit their head that it changed. When you really get into nitty-gritty of development of a person, you see that like, well, it existed, it was suppressed. There was something that suppressed it. And the only way that we can be is to remain open-minded and neutral in every single question from the beginning and get-go. That's it. Like, you know, we definitely have to refer to people one way or the other, but we also have to be very careful and mindful about what we're asking, how we ask about someone's sexual life, how to remain neutral about it, about the person. Like, words are very important, such as asking, I would like to ask you about your romantic life, rather than do you have a girlfriend or a boyfriend? Like thinking about like leave the door open for not having anyone, not being interested in anyone when exploring someone's sexuality. Of course, it needs to be developmentally appropriate. For a 12-year-old, the questions are going to be very different to a 20-year-old, to a 30-year-old. I'll leave that to each person's experience and the field that they work, but integrating that neutrality into our language is going to be very important. Integrating that neutrality to the way that we think is going to be very important, because what we think and what we feel is going to come out one way or the other, either unconsciously or overtly by like something that we say. And we set a presence in our sessions, what we use.
Shervin, it's Melanie. I just wanted to ask a question there. So I'm thinking about when a client comes to see us as clinicians for the very first time, if I introduce myself, hi, I'm Melanie, and my pronouns are she and her, is that appropriate to do that with the idea that I'm trying to set it up so that the client might feel comfortable to then use their preferred pronouns? Or do you like to just directly ask what pronouns do you prefer? Is that a good start point when you're meeting someone for the first time?
No, you ask a very good question and a very difficult question to answer as well. And it is in some way individual approach. I can share with you what I do, but I also can sort of like bring up some of the different perspective into it. If you see, I put there, be careful about disclosing as well, because I think you can set a tone in the session and expectation in the session. If I introduce myself, say, hey, I am Shervin, I am a cis male, heterosexual, homosexual. I said, well, hi, I am Shervin, I'm cis male, and I identify as gay, and I use he, him pronoun. I set a very strong tone for the session, expectation of the other person to disclose it. That is my view of it. Yes, I agree. I think we can do what you are raising, Mel. It is a very important point, is that how to show to the people that we're working with that we are open-minded and we are open to listen to everything. But also, so I think as much as we serve like kind of like, we have to be able to serve everyone. So, and we have to make sure, like, what if a person is gay, but is pretty homophobic still about themselves? And that might actually push them away very much. I suggest that we can actually do other things to make that message, to cross the message, but people do it differently. Some people leave elements in their system, and I think it depends on the setting. In a hospital or in a clinic, you see often there are people put elements there to welcome it. They can leave a rainbow flag. They can leave a trans flag there. They can do these. They can put like the optional questions. I don't have an answer quite clearly about it. I think this is something to think about, the benefits or lack of benefits. One of the things is that depends in what setting and how we're going to work with the person. If this is the only opportunity to get the information, and after now there won't be too many individualized contact with a person, you may need to get them. If to get as much as you can in a welcoming and a neutral and not pushy way. If there is an opportunity of working for another 50, 100 sessions from now, why should I rush? That's my view. I have a lot of time to explore it later. I think it's based on the setting, people may decide how they want to do that. But the idea you brought up, I think is a great thing to think about as individuals are planning to set up their settings. I hope I answered your question.
Yeah, no, that was very, very helpful. And as you said, it depends on the situation. So it is quite tricky, isn't it? Because you want to set the tone, but I realize from your explanation, it can come across as too much depending upon where the client is. So again, this is why we're having this webinar, because it's really helpful. Thanks, Shervin. I think we've got one other question here, which is, if I may, with treatment for adolescents, this is from Ashley Jennings, with treatment for adolescents, how do you approach these questions or addressing some of these hypotheses when parents do not know about their child's LGBTQ status?
Oh, well, thank you, Ashley, for raising that question. I think the same rule applies, is that we have to be ready and very careful about confidentiality. I do not see any reason to cross that bridge for it, like with any adolescent, and disclose it to parents. In fact, it can be very dangerous. I would go only, I would ask them in a private setting, if depends. if a child is coming to me, an adolescent or a child is coming with their parents, seeking care related to their gender, that's a different story. They already have set a tone and come to my office. Still, I will leave some time alone with the child. I think it's important to respect privacy and to ask the question in a private setting and make sure that we can protect it. Some people go as far as be careful where you document it and who sees it, because you might run the risk of one of your colleagues disclosing early, running the risk of early disclosure, early outing an adolescent, and that can jeopardize not only your alliance with the person you're working with, it can jeopardize safety of an adolescent. Well, or it can actually, like, outing a person is without their permission, even if it doesn't put them at the risk. It is kind of quite disturbing.
Yeah.
It is very disturbing. Really having that discussion. And you know, sometimes I even like if it's my private practice, I own everything, so I'm in charge of it, unless there is a breach of like the whole chart is stolen electronically, whatever happens. But if it's in the hospital, I usually ask people and they've asked me, do not document it. I do not document it.
Right.
I've been really giving this, and I hope they answer your question actually, but I wanted like a little branch of this question is that how to ask questions is the second part. Is really I encourage people to think developmentally based on their level of like the type of training they've had working with different ages. It's not only adolescent, actually, young adults also. Young adults live with their family. They can be dependent on their family. College kids are actually very much dependent on their family. Most people are not fully financially independent at the age of 18, 19, 20, 21, slowly starts doing something at early 20s. So, and even later, risking of outing someone can be quite disturbing. So thinking about all of them is that like the other part is that think about how to ask this question first and who to ask it. Want to use your question, Ashley, and a little bit branch off in terms of who to ask and how to ask it. How to ask it is really a developmental question. I think you can ask this question from any child as long as you know how to ask it age appropriately. I have seen some places people come up and say that, well, ask question about sexual orientation only at kids above age 13. I don't agree with that. I think if it matters and if it's present, like it's something that comes up in our work, there's no reason not to ask it. A 10-year-old or a 9-year-old might have started thinking about their own attraction. And if I close that door altogether in my mind, there's going to be no opportunity for this child to disclose it to me. Or if someone is married to a person and based on their marriage status or current relationship status and their look, I close that option. I want to go all across the board. If I close that option in my mind, that this person is straight and cis, I will never be able to actually be able to listen to the person in front of me, that what stories they have inside themselves.
Sure, absolutely, absolutely. We have another question here from Laura Landau. In fact, Laura has her hand up. Laura, I'm going to unmute you if you'd like to ask your question, if that feels comfortable. Go ahead, Laura. Laura, can you hear me? To unmute. Laura.
Hi there. This is an amazingly, terrifically helpful presentation. I did not have a question, however.
Oh, great. But okay, no problem at all, Laura, but thank you for jumping on and telling us that. I will go ahead and mute you so you don't have to worry about noise, and we'll go back to Shervin.
Thank you.
Thanks, Laura. Over to you, Shervin.
Okay, perfect. I think picking up my own momentum and going back to my own thoughts about I put the next slide as key points related to sexuality. Kind of like, thought about and talked about a little bit answering these questions, such as when you ask about these questions, really, I don't want to say when to ask it, but I think we need to think about it and ask it. I'm not sure if there is any person here who is working in an acute setting that you're going to see the person once and you don't know when you're going to see them next. That might be your only opportunity to think about and ask it if it's an acute setting. but if it's a long-term setting, you might have other opportunities much later. The exploring and thinking about it and leaving the door open for more questions, more information, I think is the key. And how you integrate it is, I think, based on each individual setting and in what capacity they're working with a person. Really want to think about, like, you know, a little bit a little bit to step back and think about it's not only about the clinical work and asking about things, it goes beyond that. Some people come to us and tell us where they are, like they identify LGBTQ, or at some point later they're going to come out and tell us. Is about like they might feel, hopefully will feel comfortable. Is about not only thinking like, you know, we addressing the eating and everything. Is about thinking of support system. The support system might be different than a non-LGBTQ person because the understanding can be different. And utilizing these support systems such as groups, LGBTQ groups, such as peers, such as addressing what is going on in other aspects of their life can be very important. Thinking about the home environment for a person, it goes actually beyond, like, I think the eating is sort of like the eating transcends itself in different layers of our life, the same way that sexuality and gender do. At home, we do eat, at work we do eat, at the school we do eat. All of these things, they connect all of them. Thinking about all these places can play a significant role in addressing the eating issues of an individual. Think about rejection, discrimination can actually help us think about their eating issues as well. One of the matters is that, like, you know, the question, like the traumas and the risk an individual is facing. I'm bringing these ones up quickly, like brushing over them, but then I might do a disservice too quickly, like mentioning them. Not that I don't want to, well, I want to emphasize how important some of them are. The risk of trauma, unfortunately, is much higher amongst LGBTQ people, not just because they were born this way, because the society can be quite cruel. And from micro traumas, such a microaggression in the environment, when I say micro, is that like the very subtle jokes, the not even so like clear that one can say, oh, that was rude. Did you use the F word? Like kind of things like that. No, I'm not talking about those ones. I'm talking very, very subtle ones that joke. And even like people think this is funny and this is very gay friendly. This is very trans friendly, these jokes, or ask, oh no, I'm only curious when I'm asking, well, what's going on down there when you're transitioning? These kind of tones, like these curious questions, so and so. So who is the boy, who is the girl in your relationship? All these type of comments that can be quite commonly asked and used in the society can be as little as like kind of, it's not even little, these micro traumas add up and the microaggression add up from the very loved one and support system because of the lack of education perhaps, to really a macro traumas and a big aggressive behavior. We're going as far as physical assault to sexual assault. We know that the LGBTQ youth are at higher risk of being sexually assaulted by the mere fact that they slightly look different and they can be targeted. That is saddening, that's horrible, but it's happening because, like, well, unfortunately, in New York City, we probably, like most of the people that individuals on this webinar serving are not homeless, but we know that like the homeless people are like majority of homeless youth in New York City are LGBTQ. That's the very end of it, like someone being kicked out of home. But I don't think our youth are sort of like are ignoring that. They actually see it and feel it in some way. It's sort of like it goes through different layers of society, what exists, the level of aggression and in different levels, and individuals can feel it. I think I talked about risking outing someone and how can it impact it, and really thinking about it as we asked this question when Ashley asked her question. Wanted to a little bit sort of around, like specifically around working with transgender people, what to consider is that, like in the beginning, it's about like, I think I've already talked about them, I don't want to repeat it, but a few key points are very important. One is that pronouns are important. yes, Mel, you said that in the beginning, I can set a tone. That's one way, but I think the other way is that when it comes to that, asking and respecting it and thinking about it, and we all going to make mistakes. If I'm working with a trans feminine person who still looks like very much masculine, the chances are the background of my mind is going to make a mistake and call her he, or make a mistake like that. And I think those are really good opportunities to catch yourself in a genuine way, an opportunity to see how the other person reacts or what they have experienced when they're misgendered. I think rather than being ashamed of it when it happens, I definitely want to correct myself and I want to apologize to the person, but really I want to be careful, but also when I think what happened in me. And when it's helpful, be honest with the other person. One of the things I catch myself, if I'm typing a note and I notice that I'm misgendered, I'm using the pronouns in my note without knowing it of the pronoun the person doesn't want me to use. If I'm referring to him as she and I keep referring to that, I have to think about myself. What is it that I'm having a hard time when I'm typing my notes, that my pronouns are not matching what the person I'm working with is asking me? I'm talking as far as that to the session, even with them. So all of these things I think that matter is about how to join the person, understand, even if sometimes I'm understanding their struggles or the struggle of people around them and the dynamic that is going on within them. Almost everyone here is going to work to a degree with their families. That might help you even understand some of the difficulties in the family when they're trying to either embrace or they're having a microaggressive or macroaggressive behavior within the family and the use of pronouns. I think, well, look, if you're not specifically working with transgender people, you're not going to necessarily know the medical interventions. I'm going to go over them because I think it's helpful to know them. It is helpful to know them and to know that how to integrate them into the care of the individual that we're working with. If a transgender person you're working with, either if it's an adolescent or an adult, understand that what is an appropriate level of care and how to integrate it and what should happen. I think having some knowledge about it is important. And quite frankly, when there is a question, reaching out and asking, getting supervision, seeking some support and expert help is not a bad idea when we don't know it. It's good to ask someone, well, look, what do you think I should do? Because I don't know exactly. I have some questions about it. Reaching out to there are several institutes in the city that they're providing help, and reading about it a little bit more. I would like to go Mel, is there any question, or can I move on to medical interventions in transgender care?
Yep, go ahead, Shervin. That's great.
I thought it would be helpful to at least summarize the interventions that are done and the appropriate ones that are known appropriate with steps to take care of transgender individuals. What do we do? It is an evolving field, but the data is good enough that we have an idea of what we should do and what is medically appropriate. You might see or encounter things that are sometimes outside of guidelines, sometimes medically inappropriate, sometimes whatever the other reason. I'm giving an overview and I'm happy to answer any questions as they come up. One of the most important things is that what we talked about, a lot of them are about social transitioning. When a person transitions from one gender to another gender and socially present themselves. They're also legal transitioning as well. Someone changes their name, someone changes their IDs, and all of these things matter. Also, what I'm talking about in our webinar tonight is that about the medical aspect of it. I'm happy to answer the other two as well. One of the key points is about hormonal treatment. The puberty, the whole Big Bang starts with the change in hormones. All kids roughly have the same amount of sex hormones in their body, very little, and their body don't change. They look like the same. If they cut their hair, they change their clothes, like they will look the same. If they grow their hair, the way they present themselves, they will look like the other gender. It's very easy to move between the other ones. But once the hormones start, the whole thing starts. So first thing is that there is a role in adolescents who are starting puberty, or they have gone through puberty, as because the puberty doesn't stop. Like let's say like a 14-year-old, 15-year-old doesn't really look like a 24-year-old. Their bodies are very different, still developing. Either from the size of breast developing, to the hair growing, to like the masculinization of the skin and the body, all of them are changing. One is that we can and we do have the ability, and is well-known medical level of care, to stop the puberty and give the person a break as they're exploring. Like, take away this one. Where is this coming from? This is coming from the old, like, kind of our treatment we've had in endocrinology, in medicine, that if someone goes through puberty way too early, we stop it and give them time to reach the appropriate time age. In some way, it might be too early for them. So if you see like that is happening, if you see someone is doing that, that's an appropriate level of treatment. In some way, actually, that's what the kids with their eating disorder, like with anorexia, they're doing. They're trying to stop their puberty, but we can do it in a medically safe way for them. The puberty has to start, of course, before we do that one. But that's a very well-known treatment. You might come across it here and there, like if you work with an individual. The second one, which has to actually be, the person has to be of certain level of development, certain level of like persistency and a stability around the gender, is using the cross hormone, which the body starts changing. Someone who was born with the gonads of female, was developing female, either stopped early, or as they're going through it, or they're fully gone through it, they can start testosterone and masculinize. Or the opposite. If someone who was going through the male puberty doesn't match with them, they can start estrogen and feminize. And the female features can develop breasts, like lose hair slowly, or if it's stopped early, they're not masculinized enough, like they can actually look fairly like easily transition to feminine look without, such as like hair removal and all of these things. Beyond this webinar, but these are all like all the interventions, at least the basic intervention one needs to know. One important key that I would like to raise here is that as a general rule, like kind of rare exceptions, still, like I'm happy to discuss them, but as a general rule, I don't see any reason if someone is in need of medical care, like hormonal treatment, that should be delayed because someone has an eating disorder. I've heard it. It's a similar thing in the past that existed, was saying that, well, you know what? Well, you're transgender, but you have borderline personality, you have depression. Let's just treat those ones and then we come back to this one. That was completely inappropriate. Like, you know, well, yes, we're talking if someone is completely like kind of all over the place, like if someone having a psychotic break in the middle of that one, no one wants to like start changing the hormonal treatment either because things are not reliable. But really, like ignoring someone's gender development or their sexuality development, in the whole reason I want to go back and refer to the slides in the very beginning of it, I hope they were not too boring at the time, is that how they develop parallel with each other. The body image, the habits of eating, as well as sexuality development, as well as gender development. They are intertwined, they are transcending amongst like kind of different layers of identity, and they're affecting each other. Ignoring one of them does not help rethinking in a holistic approach and understanding a person's identity as a whole rather fragmented.
Shervin, sorry to cut you off there. If I may ask a question, gosh, there's so much there. I imagine that other people listening, their heads might be exploding at this piece, because I'm thinking of families and I'm thinking of parents specifically. Mm-hmm. And I'm thinking how hard it must be as a parent when your child who's just starting to go through puberty perhaps then lets you know that actually this is not okay and I don't identify as becoming, becoming a woman or becoming a guy, depending upon, as you said, anatomically, biologically, how they're set up. That is quite a progressive adult or parent, I would suggest, that at that young age for their child to say, okay, we're going to go ahead and do hormonal treatment according to what they feel is their sexual identity. Maybe I'm projecting, I'm sure I am. I've got my own thoughts there about how many parents could wrap their heads around that and trust that their young child knows what they're talking about, as opposed to invalidating it and just saying, oh, it's just a stage and you'll grow out of it or whatever. So I've thrown a lot at you, but I guess what I want to ask is, what have you seen in that situation with how parents might react to that?
Perfect question. And thank you for asking it, because that's a reality on the ground. And in fact, this journey is not done without the parents. See, like, because I don't think parents' concern is they are irrelevant. In fact, they can be very helpful. I describe them sometimes when I work with parents and kids. I said, like, well, you as parents, you have your concerns are like your wheel of this car, and the kids are like, please remain concerned about them. And the kid's energy is the engine. The real deal is that, first, not everyone who has a question about the gender during the development, during the adolescent years, they're going to end up necessarily wanting to have the hormonal treatment. So based on the age, some of them, they don't. That's why the hormonal blocker, which is a fully reversible treatment, comes into play. But more importantly, I want to actually a little bit look at it from the family way, lens, is that majority of parents, even the parents who at times might have their own selfishness, their own complexity and everything, they have some investment in their child. I really want to use that investment in love and work on it, put a hook on it, let them ride that love horse, and help them to find a way to help the child. Work with families. Sometimes, unfortunately, it didn't work, but even but really entering the family, I think, is an important piece of it, and helping them understand, rather than avoiding pouring fuel into the fire if it exists, helping actually extinguishing the fire and bringing the connections can help. The kid is raising a question that can be anxiety provoking for parents, and they have a ton of questions. I think each individual who is working with his families, no matter what capacity they have, can play a significant role in helping those parents first respect. Some parents actually go to the opposite. Some parents, they become really ashamed of and embarrassed about their own anxiety, and they go to the opposite, to the point that they don't want to even think about the possibility of doing something that would upset this kid. And I might not be necessarily helpful as well. The parents have to be, to a degree, concerned about what's going on with the child. They have to be if the kid is doing things that they don't agree and they don't go with the family's rules, they should be able to stand up against the kid and tell, no, you're not going to do that. They have, in an eating disorder setting, they have to be able to reinforce some eating habit behavior, and it becomes, because of that, it actually becomes way more problematic. I think one of the matters that you raise is that being able to look through all of these lenses and angles and help the families who have an LGBTQ kid or adolescent that they're working with, and the kid who is working that we're working with, understand that how that can actually a little bit complicate the dynamic. Engaging in feeding a child is already hard enough, because we're going against the development, and at the same time, when someone is really angry and their relationships are intense, it can become more problematic. I think finding their connections is going to be very helpful, and the reason they're concerned for the kid can be very helpful. I have seen families from really and I think really turning off our assumption about the culture and their decision can be very helpful. I've seen the most conservative families sometimes coming really forward, and I've seen what it looked like to be very progressive family really struggled with their own fear. But that doesn't mean that I think that a struggle of a parent who is even otherwise in many ways progressive can be, it is meaningful. It is their struggle, and that kid cannot safely transition or get proper treatment unless we address that one. Similar to a situation that if we have parents who have really difficult eating habits, and their eating habits are are really across the day-to-day of their life, and they have some understanding of food that are really quite difficult for the child, and a child who is trying to eat, and the constant messages about this food is unhealthy, that one is this, you're getting this one, look at you, no one is going to look at you. this language, we really have to think about address it appropriately in a family setting. I think the same thing applies here too.
Yeah.
I don't think a parent wants to hurt the child, but their own complexity is hurting the child. The mother or father who is talking about about the food in a way that is very disturbing for a child, like the magazines they have at home, all of them they are.
Absolutely.
Interesting that it doesn't even stop. Like you may see all of these struggles even with LGBT families, LGBT parents who have a child who is LGBT. Sometimes they may have the similar struggles because they saw it through another lens, another generation. That's a different generation and different things like that. And they think they know it, but they might not know because they have their own struggles too, like any other parent.
Yeah, absolutely. Absolutely. I have another question here for you, Shervin, from Gillian. Gillian says, just to confirm I understand the difference, the hormonal blocker is only if it is early stages or the person is exploring, and the cross-hormonal would have to happen eventually for a full gender transition. Is that correct?
Yes and no.
Okay.
In a sense that, well, there is an assumption that hormone blockers are only helpful when it is the very beginning of the puberty. Some of my colleagues even talk about that, but I don't think that necessarily is correct. Like if someone yes, ideally, when I'm saying ideal, not because of what we do, because it's sort of like, the ideal case of like a presentation, but people don't come in one way. They don't always find out about their own gender at the very beginning of the puberty. Sometimes, often the puberty happens, and we don't kids don't necessarily start talking about, I'm angry, like kind of like with my change. The moment they have breast budding, they might have developed quite significant size of breast, or their height might have already stopped. The bones have fused for someone who's gone through female puberty, and their height has no room to grow more. And there are ways of, like, hormone blocker is one of them, but they're also like, even for those kids, we can still use it. I have to say, like, I think it's okay to think about them in most adolescents, even pubertal adolescents, like who've gone through puberty, such as like the example, actually, especially in masculizing hormone, a 14, 15-year-old, a 16-year-old, like they don't really look like a 26-year or a 30-year-old. I used to have way more hair here. I don't remember I had this beard when I was a kid. Like I didn't used to shave when I was 14, 15-year-old, but my voice had deepened, I agree. Or started cracking at some point. I think stopping them at any point might be quite helpful. Is the ultimate step cross-hormonal treatment only if the gender persists? And only if the person reaches adequate level of development, or if not, then it becomes really complex, such as someone who has difficulty reaching development, let's say have developmental disability. Those are a little bit more difficult, needs a complex decision making. But as a general rule, people reach at some point the gender stability. Maybe some people say age 16, roughly around that. Some people reach early a little bit, some people later. Or as long as they're in the phase of exploring, the hormonal blocker can be an option. The other ways of blocking hormones, the different ways of blocking hormonal treatment, hormones in the body, and for all of those matters can be used. The cross-hormonal treatment, if the person persists still identifying with a gender that they desire, which is different than the gender they were assigned at birth, then it becomes a treatment option. I don't want to say this is the only thing, because there are a lot of matters to think about, such as fertility, such as sort of like the side effects of them. Doesn't mean that you shouldn't do them. That means like you have to think about them too. Beyond this webinar, but all of them I think are helpful to think about them. I hope I answered your question. If not, please tell me.
Sure, absolutely. Thanks, Shervin. And then there's one more question, if I may. Are you okay for time if we take this question now? So that
I think we still have half an hour, am I right?
15 more minutes.
15 more minutes, sure.
Yep, 15 more minutes. Yep, we're great. The next question, and Gillian says, thank you. That's great, Gillian. The next question is from Emily, and she asks, what impact does the coming out experience or lack thereof have on the development of an eating disorder in terms of a traumatic experience or a turning point in one's life? So in other words, the coming out experience is a traumatic experience, if I'm understanding that question correctly.
You know, the honest answer is that I don't know, because, and I'm saying it because I think it can be very individualized. Thank you, Emily, for raising that question. And the reason I'm saying I don't know is actually to leave the door open. I think you raised a very good point, is that how coming out can impact it. It can be, depending on how it is received or how it evolves or where it goes, it can be very different. I think sometimes coming out in an eating disorder setting, especially, can be a pivotal point and a change. Like the person, by coming out or by helping the person, like, you know, when they reach that point of feeling, it indicates safety in the relationship with the family and the treatment team. And the safety means actually better rapport, and may mean actually transitioning out of using eating as a mechanism, or eating might have already unfortunately established as a pattern by itself. I have worked with transgender youth that the anorexia became a habit of eating despite transition being on hormone. And I have worked with the ones that actually, by coming out and starting hormonal treatment, everything disappeared. Like, it is very individual, like I think person to person. Or I can think of people who actually, they came out and became so chaotic around them that it exacerbated the situation. Have had less of the latter, perhaps, sort of like, as I think often within these sort of things have been quite, or I have worked with adolescents that they had mentioned something about the gender and sexuality, they decided to never talk about it. Did they change their mind? Maybe. Did they decide not to talk about it? Maybe. Parents, actually, it's interesting. I've had experience, parents asking me, we think our child has a question there. What do you think? We think by, like, kind of talking about it, that might help with their eating disorder. But anytime we talk about it, this kid says no. Like, they shut us off. And I said, well, look, actually, the kid did that to me too, like, kind of when I was even exploring. And this is quite informative. I think the kid is giving a very clear message that I am not ready. I'm saying the kid might be an actually young adult. I'm not ready. I can think of some young adults that I work with. They decided to come out to, like, in a family setting. When I work with these families, sometimes, like, sort of as young adults, as their mid-20s or late 20s, when they decided to come out, their life took another turn. And it said, like, I was not ready to come out to you guys 10 years ago. And that's the dynamic. The thing is, there is no rule, frankly, for it, but we have to respect when they want to come out. It can be quite helpful if it's appropriate time, if it's individual's decision, and if it aligns sort of like if it helps with and I think it might help with the relationships as well.
Yeah.
I hope I answered your question. If not, please.
Thanks, Shervin. I think that was a great answer, and it brings up this idea around, because with eating disorders, when we think about our clients who are so ambivalent, we think about them being in denial around their eating disorder. And it's very important from your explanation to not think of, the kid being in denial per se, but really being very respectful about they're not ready. They're not ready to talk about it or to come out or whatever, and to be respectful of that.
Denial isn't a defense. If you want to break it, like, you have to be ready. Like, it's hurting the person, and I don't want to break it so easily.
Exactly. That's what I was hearing. And I just got a big thank you here on our checkbox. Thank you to Bobby for that. And I'll let you proceed, Shervin, because I don't want to cut you off so we don't get to the end of your slides.
No, speaking of, speaking of hormonal treatment, one matter that came to my mind, and I think it came to your mind as well before, as we were talking about this webinar, was that the ideal body weight in transgender patients. I don't think in the rest of LGBTQ might come up as much as amongst transgender individuals, is that, do we have any data saying that if someone is in another hormonal treatment, how to calculate that one? There is, I don't think, as far as I know, there is no clear data saying that this is how you need to calculate, but there is some consensus amongst, especially I have to say sort of like maybe adolescent medicine physicians and the ones who are working in the, with transgender youth. One thing is that to think about, really like we all have to think about the body weight developmentally, right? And calculating it very raw, like based on someone's height. What might, and many people, and I working with many people in this field, I know that that's what most people do, is that what has been the appropriate weight for this individual rather than thinking, because it might be much higher or like a little bit different than what it comes up on calculation, really looking at the developmental chart. The other piece is that I think the start of hormonal treatment, everyone agrees, can play a role. And there are a few matters about it. One is that really could, like, such as if someone goes on testosterone, really thinking about they may need a higher weight, and have to be aware of that, because like they probably, they may be a little bit off the chart in the sense that they may need a masculine, because the body, when we start hormonal treatment, one of the first thing that changes in the body, and probably very reversible as well, is the fat redistribution and the fat content of the body. It does change within the first few months of the start of hormonal treatment before anything else changes. One of the very first things that change. The muscle content to start changing. So really thinking about those ones, have to think about, like, really have to have an open mind, like kind of, and be a little bit more cautious and think about like, kind of like, is this matter, how is it going to apply to this individual, and be more conservative, right? And such as like if someone has anorexia as a trans man, I'd like them to be slightly on when they go on hormonal treatment, especially if there's an indication of restriction and the weight is not sort of like, seems to be like, okay, there might be actually low weight at that time. I think that's something to think about it. And the other piece is that many of us are familiar with the impact of eating disorder on bones. For an unknown reason at this point for us, the etiology is not really clear. Trans women are at high risk of osteopenia and osteoporosis. We don't know really why, like, and that's much higher risk. And we know that like eating disorders impact the bone as well. Is it actually because of eating disorder habits or disorder eating habits amongst trans women? Traditionally, when you look at them, like the data comes from people who are actually older generation for like different ages, that they were often being thin to cover up to get rid of masculinity. Has it been, that's a hypothesis that has come up in as much as like kind of a conversation, nothing more than that. I don't think there is enough data to hold any water like for it, but this has come up. Unfortunately, no one has really looked deeply into the role of disorder eating or eating disorder amongst transgender individuals, in a sense, like in a large community. And also the pool is pretty small and the access is very hard. But that might be like one of the matters. Is it, or is it because of the societal changes, marginalized life, substance use? We don't really know. Could be a variety of reasons, but that we know that it is actually. So there is this opinion. I wanted to put a quick slide about surgical interventions because I think it matters. Like, you might hear about it, you need to know about it. Like, people might have heard of top surgery. Top surgery often refers to the chest. An individual who has developed breast wants to remove the breast. It's different than breast removal, mastectomy for cancer. In that type of surgery, the entire tissue often is removed, or removed in a sense for tissue to be preserved, like a part of breast is removed, and try to do it plastically in a way that the breast look like is maintained. But in a transgender care breast removal, the female breast is removed either by keyhole surgery or a bigger surgery and reduce the chest contour to the way that it looks like a masculine chest. Masculine chest has breast tissue as well, and for that reason, people actually, like transgender individuals who've had a breast chest or top surgery or mastectomy, they still remain at risk of breast cancer because they have breast tissue. Or for an individual or a breast or a transgender feminine person who has breast augmentation. the first one, the former, is perhaps the type of surgery that matters most, at least in my own hypothesis or the people working with in terms of eating disorder, because it really talks about the shape of the chest and flattening the chest. People like may wear binder, may wear bands around it. Really, you know, you might be the only opportunity that, like, that young person talk to you, that they are what they're doing to flatten their chest. If they are gender variant, they might not like their chest. And top surgery might be actually like, I'm not saying this is the only way of doing it, because some people may only want to flat, they don't want to remove their breast, but that's a treatment. And it used to be only for adults, but in particular cases and situations, even adolescents can be an appropriate treatment for them too. So if you're working with adolescent eating disorder, because it might be like the breast might be the main drive for the body image, and it might be one of the main reasons that the initial like stress around body image started and trickled down to an eating disorder habit or disorder eating habit, and then became an eating disorder, full-blown eating disorder. The bottom surgery is when the genitalia surgery is done. Creating a penis is a very hard surgery these days, often needs multiple surgeries and semi-successful, still developing. The one that is more common done is vaginoplasty, creating a vagina. I don't see much relevance to eating disorder, but but one of the pieces is that if someone is going through a surgery and has an eating disorder, malnutrition means poor recovery. Really sort of engaging in those one, or like not only malnutrition, if someone is actually has been eating in a way that the weight is higher, and it could be so, like you can imagine a trans masculine person, for example, if the weight is higher, the chest is disappearing in the rest of the body, extra weight. The surgery can actually have extra skin when they have surgery, and that might be a decision to think about how to address eating disorder, like the weight or eating habits before surgery or after surgery. When someone is malnutrition, the surgery recovery is going to be very hard. I think that is something that the hormonal treatment might not be as difficult, but the surgery might be difficult. If someone is cachectic, like I don't think they're actually good candidate for surgery, and there need to be some restoration of the weight and some stability for that, because if someone is purging and they're going to vaginoplasty is something that needs really, like, the post-op care is very important in terms of like maintaining vagina opening, making sure it doesn't prolapse, the increased pressure inside the body, all of these things. It's quite a big surgery. I think so. Those are really like thinking about integrating eating disorder treatment into the treatment before that surgery is very important. Thinking about it is very important too. You might not see them often, but I wouldn't be too surprised that many people on this webinar in future are going to be involved in that. And I think I have talked about most of these matters, such as like, thinking about, I'm reaching the end of my time as well. I think I have actually talked about most of them. Yes, and the main thing is that thinking about, if you have a gender variant person, you might need to integrate transgender care into the treatment as early as possible that you can. The last but not the least, I would like to bring, like, people who have come here, I believe you had other question and interest in this area. Like, do not forget, advocacy and education is the key. The reason LGBTQ community, so as many other minorities, are having difficulties is because there is discrimination, there is injustice in the society, in almost every society, and these are impacting people's life. There is never enough advocacy for social justice. From one end you do it, from another end is poor. It's like a barrel that has a huge pour at the end. No matter how much you pour into it, unfortunately, the other end, some people are emptying it and are destroying it. There is never enough advocacy. Every person can be an advocate in their own role, working with an individual. From talking to legislators, and I'm not sure if anyone is outside of New York. New York has established laws protecting LGBTQ people, to school for a person, for you to know, if you're working with adolescents, there is New York State has the Department of Education in New York State has a comprehensive guideline about protecting LGBTQ, in particular, actually also for the transgender youth. If the schools are not following it, they're actually violating the Department of Education. Even private schools, they're getting money from the New York State. Unfortunately, after Trump took office, they rolled back a lot of federal protection for the schools. It used to be any school getting any federal or state money, they had to follow them. Sadly, like many other things that Trump destroyed, he destroyed one of these things like a part of his destructive machine. The work environment is very important, thinking about how you can advocate for the work environment for an individual or the home environment. There are a lot of things we can do. Lastly, but not least, are the ton of organizations available out there that they can provide information, they can provide support, ranging from like HRC at the national level to local, such as like LGBT Center in Manhattan, such as like places like the centers, the transgender care centers in the city, to like variety of organizations available to support families. PFLAG for supporting families of young people who are LGBTQ, all of them are very important, and you can find them and get help from them. And I would like to end it to at least get some reference to people who were on the call. Think of, if you want to know more about it, I would say the most comprehensive reference that I would like to mention here is WPATH. Many people may know it, maybe people may not. WPATH has a long history in terms of providing care for transgender people, and that is a Work Professional Association for Transgender Health. It has a standard of care, hopefully will be updated. It's not Bible. You can, like, things can actually deviate from it to a degree, but it can help people. You can find sections of it relevant. It doesn't have, unfortunately, anything around eating disorder at this point, but I think you can use them. There are other things like that I use in this present, such as Pediatric Endocrinology Society has a good guideline. American Academy of Adolescents and Psychiatry has good materials around eating disorder, around working with LGBTQ youth. Fact for Families are very decent, summarized, like one page. You can give them to individuals to read them, or things such as practice parameters, more for child psychiatrists, but I think Facts for Families could be very helpful materials to hand out and help people rethink about them. Okay, I am going to stop at this point and take any questions.
Oh, Shervin, that was just brilliant, just brilliant. Thank you so, so much. And gosh, I've learned so much from you tonight. And for all of our listeners who joined us, thank you so, so much for joining us. And I'm sure and I hope that you feel that you've learned a lot tonight from you as well, Shervin. And also I have a message here from a wonderful Leslie Davenport, who is our outreach coordinator, letting me know that we will be following up with everyone who listened tonight with a link to the recording from tonight's webinar, so that you'll also have that to refer back to, and those wonderful resources, Shervin, that you highlighted for us at the very end. So thank you for that. And I'm conscious of the time, so I know that we do need to say our farewells, and we took some terrific questions during, but I can see that actually we probably need a part 2, because there's just so much that we could dive into, you know. So I just want to thank you again, Shervin, for really giving us a nice overview of everything from terminology to treatment to eating disorders and how they intersect. It's just it's an area that we all want to and desire to be more sophisticated in, because none of us want to inadvertently offend any of our clients, of course not, especially when they may be grappling with so much discrimination in society anyway. So what a wonderful head start we got from tonight. And some thank yous are coming in the chat box as well. So to our listeners, we will end it there, and